morning, ma'am. I'm Dayaro Sharana from BSN1E, and today I'll be going to perform the assessment of the thorax and the lungs of the patients. And the first thing that I will going to do is to introduce myself, verify the patient's identity, and instruct the patients of what I will going to conduct. So, good morning, ma'am. I'm your student nurse for today. I'm Dayaro Sharana. So, ma'am, may I know your name? Okay, ma'am. So, when is your birthday? Okay, so today, ma'am, we're going to inspect, palpate, auscultate, and also percussion the various part of your thorax and lungs. In order to do that, ma'am, could you allow me to touch the various part of your thorax and lungs so that I could be able to know if there's any abnormalities, findings, and so that I could be able to give you an immediate care. So could you allow me to do that, ma'am? Okay, so the patient's allowing me to touch the various part of her thorax and her lungs. And then next, I'm gonna perform hand hygiene using an alcohol. Okay, and then I'm gonna close the curtain and the door for the privacy of the patients for a warm, well-lit room. Okay, then next, I'm gonna proceed to the subjective data. So I'm gonna ask the patient's history or health status. So, or current health status. So, ma'am, can I ask you some questions? Okay, so ma'am, do you have short of breathing? Difficulties of breathing? How about sputum, cough, chest pain, or cyanosis? Okay, so I'm gonna proceed to the past health status of the patient. So, ma'am, may I know if do you have lung disease exposure, allergies, smoking? How about medication? And also any use of oxygenation and vaccination. Okay, so let's now proceed in inspecting the anterior thorax of the patient. So I'm gonna anterior of the patient. So the first thing that I will going to do is to position my client to a comfortably sitting position with cloth removed except for the examination gown and drape. So however, if I do not have these two, let's just imagine that I have an examination gown and drape. So next, I'm gonna instruct my patients to breathe normally. So ma'am, could you do that for me? Okay, so next is I'm gonna observe for the patient's color skin. So I'm gonna start. So let's observe the skin color from head to her toe. So rest of the body, including the nail bed and also the lips. So I'm gonna start. Okay, the nail bed, ma'am. Okay, the lips. Okay, so the skin color of the patient is consistent up to her head to her toe, as well as the lips and the nail bed. It seems like color pinkish, which is indicate in normal oxygenation. So let's now proceed in inspecting the structure of the thorax, slope of ribs, and the symmetry. Okay. Okay, so it seems like the clavicle of the patient is at the same height. The sternum is in the midline. Also, as well as the costal angle, it seems less than 90 degree. And I observe the chest. The chest movement is symmetrical. And there's no and also the observations of retractions such as and also there's no observations of retractions such as substernal, intercostal, suprasternal, as well as the accessory of sternocleidomastoids. So let's now proceed in inspecting the chest configuration and shape. Hi! Papunta. Okay, so the adult transverse is approximately diameter that of the anteroposterior diameter, which is the ratio of 1:2. There's no any observation. There's no any abnormalities findings such as barrel chest, carinatum, excaratum, kyphosis, scoliosis, and lordosis. She is also have a normal chest configuration, as well as while doing this, I'm already observing the respiration of the patients, and the respiration rate of the patient is 16 beats per minute, and it's normal. So why I did not tell to my patient, because the patient might conjunct the way she breathes, will lead us to not getting the abnormal findings such as tachypnea, bradypnea, and apnea. And next, I'm going to palpate for the anterior thorax of the patient. And here, ma'am, don't hesitate to tell me if you feel any discomfort or pain, okay? And the first thing that I will do is to palpate for the areas of the tenderness, lesions, masses, or crepitations of the sternum ribs and intercostal spaces. So I'm gonna locate the suprasternal notch and then move downward to the sternal angle, and then I'm going to palpate for the second rib and the second intercostal spaces, left and right. Okay, and then I'm gonna continue palpating from the sternum to the xiphoid process, left and right. Okay, and then count the ribs. Okay, so it feels like the sternum is flat except for the ribs of the sternal angle, and also the ribs, it feels smooth, as well as the spacing of the ribs and intercostal is symmetrical. Now let's proceed and lightly palpate the anterior thorax of the patient. So I'm gonna use my finger pads, and then I'm gonna begin at the above the clavicle, left and right, then below to the costal angle, and laterally to the mid-axillary line. So again, ma'am, don't hesitate to tell me if you feel any discomfort or pain, okay? So do you feel pain, ma'am, or discomfort? Okay. How about in this one, ma'am? Do you feel pain or discomfort? Okay. So the muscle mass is like firm, and also the underlying tissue is smooth, and also the chest is free of lesions and masses. And also when I palpate it is non-tender. So now let's proceed in palpating for the thoracic expansion of the patient. So I'm gonna place my hands to the lower chest of the patients, and then I'm gonna ask the patients to breathe. So ma'am, inhale, exhale. Okay, and then next I'm gonna place my palmar surface to the patient's costal margin, and then I'm gonna place my thumbs closely to the mid-sternal line of the patient's body. So I'm gonna pinch some skin and ask the patients to take a deep breath. So ma'am. Okay, so the movement of the patient's chest is smooth and even, as well as my thumbs it's move apart, and the patient's skin is smooth as the chest expands with inspiration. And next, I'm going to palpate for the tactile fremitus of the patient. So here, I'm gonna feel the vibrations of the patient. So the patients will say certain numbers such as 1, 2, 3, or 99. And then I'm gonna explain to the patients that I will be touching the various part of her chest. So, ma'am, is it okay with you if I touch the various part of your chest? Okay, so and then, ma'am, I want you to say 1, 2, 3, clear and loud voice. So is it okay with you, ma'am? Okay, and then next, I'm going to place my palmar surface of the base of the metacarpophalangeal joint while palpating for fremitus. And then I'm gonna palpate and compare symmetrical areas of the lungs as I move side to side from apices to bases, and then displace for female breast as required. So say 1, 2, 3, clear and loud. Okay, one more time. Okay, so the normal fremitus diminishes as I move from large to small airways, and it's decreased or absent over the precordium. So let's now proceed for the percussion of the anterior thorax of the patient. So penetrates approximately for about 5 to 7 centimeter to assess the underlying structures, and the usual sound is resonance. And then I'm gonna begin at the apices of the lungs, and then I'm gonna instruct the patient that she need to tilt her head opposite on the percussion to increase the size of the surface, so that my fingers will be placed on that surface interference from the clavicle, and then move to the chest wall of the patients, and then place my fingers to the intercostal spaces parallel to the ribs, and then we need to and then also percuss the anterior chest, and then we need to compare the sound compare the sound from side to side, and then percussion to the base laterally to the mid axillary line. So let's start. Okay, so the percussion over the bone and over the bone or organs will yield flat or dull sounds. And also, while doing this, I'm avoiding to percuss the sternum, the clavicle, and also the ribs. And as well as when you percuss over the heart, will produce dullness to the left sternum from the third to the fifth intercostal spaces. And as well as the percussion on the left lung laterally to the mid-clavicular line. And lastly, which is we need to percuss the left lower thorax. It will change for resonance to tympani over the gastric air bubbles. And when we percuss the right lower the right lower thorax it will change for resonance to dullness to the upper liver border. So let's now proceed in the auscultation of the anterior thorax of the patient. And the first thing that I will do is to ask the patients to take a deep breath whenever I place the stethoscope on her chest. And then the patient should let us know if she was having a take short of breath or they were tired, and then I'm gonna place the stethoscope over the trachea above the suprasternal notch, and then to hear for the bronchi breath sounds. That move it from right to left side of the trachea just above the sternoclavicular joint, and then place the stethoscope at the apices of the end the triangular area superior to each clavicle to hear to hear vesicular sounds. And then I'm gonna auscultate the bronchi at the second and third intercostal spaces, and then spaces to hear for the sounds of bronchovesicular. And then I'm gonna compare the sound from the left side to the right side, and then I'm gonna move down to the six intercostal spaces and laterally to the mid axillary line. So let's start. Ma'am, is it okay with you? And then ma'am, tell me if you feel if you having a hard of breathing, short of breathing, difficulties of breathing, or if you were tired. Okay, so let's start.
Hindi dumating yung ayun. Hindi dumating bebe kay
Ano bilang tayo?
ay kader kader. Malaking yung kader.
Okay, so it seems like the respiration of the patient is normal and fine. So now let's proceed in assessment for the voice of the patient, and will remain at the same position as for percussion and auscultation. And then I'm going to listen for the sound of the patient's chest while the patient saying certain words, letters, and numbers, because I'll be going to auscultate for the voice of the patient. And then I'm gonna use the same pattern for evaluating the auscultation of the lungs. So the first thing that I will do is bronchophony. So when we say bronchophony, I will gonna ask the patients to say 99 as I place the stethoscope at her chest. So, ma'am, say 99 as I place the stethoscope at your chest, okay? Okay, let's start. Okay, one more time, ma'am. Okay, so the lung tissue of the patients, it seems like normal cause I've heard the sound muffled. And so now let's now proceed to egophony. So when we say egophony, I will gonna ask the patients to say letter E as I place the stethoscope at her chest. So ma'am, uh, say E if as I place the stethoscope again at your chest, okay? Okay, one more time, ma'am. Okay, so I can clearly heard the E through my the E of the patient through my stethoscope, and also the normal lung tissue of the patients is perfectly fine and normal. So let's now move on in percussion for the posterior thorax of the patients. And so I'm gonna visualizing for the landmark, observe for the posterior thorax, and visualize for the horizontal and vertical lines and the level of the diaphragm and also the features of the lungs. And then I'm gonna explain to my patients that I will be tapping her chest in a variety areas. So is it okay with you, ma'am? Okay, because percussion allows assessing of underlying structure. And since we all know the usual sound in the thorax is resonance, a long, low pitch hollowed sound. And then I'm gonna ask my patients to breathe to normally breathe. So is it okay with you, ma'am? Okay, and then I'm gonna instruct the client to lean forward and shoulder and round shoulder, because this position move the scapulae laterally and permitting more areas to the upper vertebral borders and widens the intercostal spaces as well. It allows me to extend my arm fully throughout these examinations. And then I'm gonna be percussing the lungs of the patients, and I'm gonna be placing my fingers at the intercostal spaces parallel to ribs during these examinations. And then I'm gonna stand myself slightly at the side of the patient, and then to allows my fingers to lay more at the chest of the patients, and then at the chest of the patients through all the thoracic areas, and then percuss for the apex, left and right lungs, and then percuss from side to side to know to know and compare the sound as I percuss the bases of the lungs, and laterally to each mid axillary line. So let's start. Okay, so we've done. So next is percuss for movement of the diaphragmatic excursion. So in this one is required to use skin marker and ruler, and then I'm gonna explain to the patients that I will be more tapping her chest. So ma'am, is that okay with you, ma'am? Okay, and then ma'am, at 2 point, I want you to exhale and inhale, okay? Then determine the level of the diaphragm during quiet respirations by placing my fingers at the above the expected level of a diaphragmatic dullness, T7 or T8, and at the mid scapular line. And then I'm gonna percuss the steps downward until the dullness replaces on both side of the chest. And then I'm gonna mark those areas and that mark approximately at that level of T10 and should be parallel. And then I'm gonna measure for movement of the diaphragmatic by asking the patients to fully exhale. Okay, and then starting at the previous skin marking, and then skin marking at the left chest. So then I'm gonna percuss upward from dullness to resonance. So ma'am, I want you to fully exhale. Okay, then I'm gonna mark that area. So let's start. Okay. Ano? Yun yung sira mo. Ayun yung sira. Hindi siya makasama. Ayun lang naman. Hindi tagal-tagal na naman. Okay, and then next is I'm gonna ask the client to fully inhale, then hold it as I percussing from the level of diaphragm at the downward, then moving from resonance to dullness. So ma'am, I want you to inhale, then hold it. Okay. Then I'm gonna mark. Okay, then I'm gonna mark this area. Okay, then next is we're going to repeat on the other side, and then I'm gonna measure with using the ruler. I'm gonna measure it first at the left side of the left side, and then it should be 3 to 5 centimeter, 3 to 5 centimeter. Okay, so let's now proceed to the right side. So so in this one, ma'am, we're going to do the same thing. So I want you to fully exhale. Okay. Okay, and then I'm gonna mark this area. Okay, and then ma'am, I want you to fully inhale, then hold it. Okay. Okay, then I'm gonna mark this area again. Okay, and then I'm gonna measure, and then I'm gonna measure on the right side. So in at the right side, it should be 1 to 2 centimeter higher because of the location of the liver. Okay, so let's now move on and auscultation for the posterior thorax of the patients. So the first thing that I will do is to ask the patients to take a deep breath whenever I place the stethoscope to a new spot. And then the patients must let us know if she becoming tired or short of breath, so that I could be able to give her time to rest or stop the procedure. So in this one, ma'am, I will be going to place my stethoscope to your posterior thorax, and then you need to take a deep breath. So is it okay with you, ma'am? Okay, and also, ma'am, let me know if you having difficulties of breathing, short of breathings, and also if you feel tired. Okay. Okay, and then I'm gonna visualize the landmark. Visualize the landmark as I did percussion at the thorax, at the posterior thorax, and then compared the result, and then should be symmetrical pitch, intensity, quality, and also durations. And then I'm going to auscultate the tracheal sounds at the vertebral line superior to C7. And then I'm going to auscultate for bronchial sounds start at the vertebral line at C7, and then I'm gonna move the stethoscope, and I'm gonna move the stethoscope down toward T3, and then the sounds will be bronchial sounds. And then next I'm going to auscultate for bronchial vesicular sounds. So the left and then the right primary bronchi are located at the level of T3 and T5. So we're gonna auscultate for the left and right of the vertebrae at those level, and then the sounds will be and then the sounds will be and then the sounds will be broncho-vesicular sounds. And lastly, which is auscultating for vesicular sounds. So in this one is I will going to do the same pattern. Okay, so the same pattern as I did in percussion. So I'm gonna start I'm gonna start from side to side, and then compare the sounds, and then move at the apices and bases to the lungs, and laterally to the mid axillary. So the breath sounds over most of the posterior surface are vesicular. So let's start. So ma'am, as I place let's start using my stethoscope. So take a deep breath whenever I place the stethoscope. So let's start. So as I do auscultate the the posterior thorax of the patients, it seems like the patients has not or does not have any abnormalities, breath sounds, and the interpretation and documentation findings so refers to the description and interpretations of normal and adventitious breath sounds. And last one which is the data for documentations, the time and the date, the procedure and findings, and if with abnormal findings, action taken, and then a referral to physicians and intervention done.